For the mind map on antiarrhythmic agents, let's look at the background. So basically, they are classified based on the effects on cardiac ion channels and electrophysiology. So with the class one, we have the sodium channel blockers, which are membrane stabilizing agents. So they block the sodium channels, reducing the phase zero depolarization and slowing conduction. So under this, we have class 1A, 1B, and then 1C. So with the 1A, which is the intermediate sodium blockade, APD and QT. Um, the drugs that you can think of is quinidine, um, prokinamide, and disopiramide. With the effects, it just prolongs repolarization and increases the ERP, the effective um, refractory period, and it's used in atrial and ventricular arrhythmias, so AFib and VT. And the side effects could lead to QT prolongation, pulsates, the pointers, and with the class 1B, it's just a weak sodium channel blockade leads to decreased APD, and you can think of lidocaine, um, mesaletin, and phenytoin, and its effects, it shortens repolarization and decreases ERP, and it's used in ventricular arrhythmias, especially post-MI, and its side effects could lead to CNS toxicity, leading to seizures and confusion. And class 1C is very strong sodium blockade with minimal effects on APD. And you can think of drugs like propafenone and like kenide. The side effects, there's marked conduction slowing and no effect on repolarization, and it's used in AFib, AVN, RT, the SVTs, but it's contraindicated in post-MI due to post-arrhythmic risk. And its side effect, it could lead to become worsen heart failure, and also it's pro-arrhythmia. With the class 2 drugs, these are the beta blockers or beta adrenergic antagonists. And remember, all these classes are based on just arrhythmia, so they are anti-arrhythmic drugs classification. So that's the class 2 being beta blockers. So it decreases the sympathetic activity, decreasing SA and AV node conduction. I think of drugs like misoprolol, esmoprolol, and propranolol, atenolol, carvedilol, and its effects, of course, it will decrease the heart rate and decrease the AV conduction, and also decrease myocardial oxygen demand. It's just used to control AFib or atrial flutter, and SVTs and post-MI prevention too. But it has several side effects like bradycardia, fatigue, bronchospasm in non-selective beta blockers. With class 3, this deals with the potassium channel blockers, which has prolonged repolarization, increasing APD, increases ERP, and increases QT. And some drugs, amiodarone, sotalol, dofetilide, and ibutilide. Remember, there are some effects like delayed repolarization. It prolongs QT, and it's used in atrial and ventricular arrhythmias, AFib and VT. It has some side effects. For example, amiodarone has severe or several side effects like pulmonary fibrosis, hepatotoxicity, thyroid dysfunction, corneal deposits, and also sotalol, dofetilide, like the tosades, the pointers. So the class 4 actually calcium channel blockers. They are non-DHPs. So they block the L-type calcium channels, decreases SA, AV node conduction, and drugs like verapamil, diltiazem, and its effect decreases heart rate, decreases AV conduction, prolongs PR interval, and it's used to control in rate control to control if even flatline SVTs, but it has other side effects like bradycardia, hypotension, and constipation. Other antiarrhythmic agents like adenosine. Well, the mechanism behind it is that it increases potassium efflux, hyperpolarization, transient AV block. So increases potassium efflux, which leads to hyperpolarization and subsequently lead to transient AV block. And it's used in acute termination of SVTs, with its side effects being flushing, hypertension, and bronchospasm. Digoxin actually inhibits sodium potassium ATPase, increases vagal tone, decreases AV conduction, and is used in rate control in AFib, heart failure, arrhythmias, um, nausea, vision changes too, are all side effects. Yeah, so though it's used in controlling AFib and heart failure, arrhythmias can be side effects, nausea and vision changes too. With MAC sulfate, magnesium sulfate, the mechanism behind it is that it stabilizes the cardiac membrane. It's using digoxin toxicity to say this the point is to, and then its side effects being hypertension, respiratory depression at high doses. Alright, so there's a mnemonic for Vaughan Williams classes of antiarrhythmias, and so and it's very simple. So it's some block potassium channels, and that's it. So class 1 some, that is the sodium channel blockers block, and that's class 2 beta blockers. Potassium, that's class 3 potassium channel blockers, and then channels, that the C is for calcium, so calcium channel blockers. So that is for class 4. All right, so a recap. You know, the heart at the atrial region, the upper part of the atrial region, you have your sinoatrial node, and then from there you have your atrioventricular node. You have your left and right bundle of his, and then finally the Purkinje fibers. So with the electrophysiology of the cardiac conduction, note that electrical impulse that triggers a normal cardiac contraction originates at regular intervals in the sinoatrial node, usually at a frequency of 60 to 100 beats per minute. And this pulse actually spreads rapidly through the atria and enters the AV node, which is normally the only conduction pathway between the atria and the ventricles. The conduction through the AV node is slow, requiring about 0.1 seconds, and this delays provides time for atrial conduction to propel blood into the ventricles. The impulse, so the first thing is that SA node depolarizes, electrical activity goes rapidly to the AV node via the internodal pathway, and then you have your depolarization, which spreads slowly across the atria. Conduction slows through the AV node, and depolarization moves rapidly through the ventricular conduction system to the apex of the heart. And then finally, the depolarization will spread upward from the apex. So the impulse then propagates over, like I said, through the Purkinje system, invades other parts of the ventricles, and the ventricular activation is complete in less than 0.1 seconds. Therefore, Contraction of all the ventricular muscle is normally synchronous and hemodynamically effective. All right, so the schematic representation of the heart and the normal cardiac electrical activity. So you realize that at the SA node and the AV node and the Purkinje cells display the pacemaker activity as phase 4 depolarization, but ECG is the body surface manifestation of depolarization and repolarization waves of the heart. The P wave is generated by the atrial depolarization, QRS complex by the ventricular muscle depolarization, and T wave by ventricular repolarization. So the PR interval is a measure of the conduction time from atrium to ventricle, and the KRS complex indicates the time required for all the ventricular cells to be activated. That is the intraventricular conduction time, and the QT interval reflects the duration of the ventricular action potential. All right. So basically, that is. Arrhythmias consist of cardiac depolarizations that deviate from the description in what I talked about, the conduction from SA node to AV node to left and right bundles of hits and the Purkinje fibers. So what happens is that there is an abnormality in the site of the origin of impulse, its rate or regularity, or its conduction. Yes, so that is the main thing. That's the main thing that goes wrong. So the pacemaker potential gradually becomes less negative until it reaches the threshold, triggering an action potential. And there's ion movement during the action and pacemaker potential. And yeah, so like calcium influx, potassium efflux. Yeah, so that is the main thing. But then with arrhythmias, the aim of the therapy is to reduce ectopic pacemaker activity and modify conduction or refractoriness in re-entry circuits to disable circuits movement. So the major pharmacologic mechanisms currently available for accomplishing these goals are, like I said, some block potassium channels, so some sodium channel blockers, and then the block does the beta blockers. It blocks the sympathetic autonomic effects of the heart, and that's class 2. Class 3 potassium channel, so prolongation of the effective refractory period, and class 4 channels, so it blocks the calcium channels. Antiarrhythmic drugs really decrease the automaticity of the ectopic pacemakers more than that of the SA node. There is also a decrease in the conduction and excitability, and increase in the refractory period to a greater extent in depolarized tissue than in normal polarized tissue, and this is accomplished chiefly by selectively blocking the sodium or calcium channels of depolarized cells. And therapeutically useful channel blocking drugs bind rapidly to activated channels, that is during phase 0, or inactivated channels, that is phase 2, but bind poorly or not at all to rested channels. These drugs block electrical activity when there is fast atrial fibrillation or tachycardia. Many channel activations and activations per unit time. That is what happens during the tachycardia, or when there is significant loss of action potential. That's when inactivated channels during rest. And this type of drug action is often described as use dependent or state dependent. That is, channels that are being used frequently or in an inactivated state, they are more susceptible to block. And the channels in normal cells that block and become blocked by A drug during normal inactivation cycle will rapidly lose the drug from the receptors during the resting portion of the cycle. So the channels in the myocardium that is chronically depolarized, that is has a resting membrane potential um, more positive than negative 75 millivolts, recover from block very slowly, if at all. So in cells with abnormal automaticity, most of these drugs reduce the phase force loop by blocking either sodium or calcium channels, thereby reducing the ratio of sodium or calcium permeability to potassium permeability. As a result, the membrane potential during phase force stabilizes closer to the potassium equilibrium potential. In addition, some agents may increase the threshold, make it more positive. Beta adrenoceptor blocking drugs indirectly reduce the phase force slope by blocking the positive chronotropic action of noradrenaline in the heart. And in re-entry arrhythmias, which depend on critically depressed conduction, most antiarrhythmic agents slow conduction further by one or both of two mechanisms. First, being a steady state reduction in the number of available unblocked channels, which reduces the excitatory channels to a level below that required for propagation. And with two, the second mechanism, prolongation of recovery time of the channels, still able to reach the rested and the available state, which increases the effective refractory period. So as a result, early extra systoles are unable to propagate at all, and later the impulses propagate more slowly and are subject to bidirectional conduction block. So by these mechanisms, antiarrhythmic drugs can suppress ectopic automaticity and abnormal conduction occurring in depolarized cells, rendering them electrically silent while minimally affecting the electrical activity in normally unpolarized parts of the heart. So as the dosages are increased, these agents also depress conduction in normal tissue, eventually resulting in drug-induced arrhythmias. And a drug concentration that is therapeutic, meaning antiarrhythmic, under the initial circumstances of treatment, may become pro-arrhythmic or arrhythmogenic during fast heart rates. That is more development of block, and you can think of acidosis, which has to do with slower recovery from block for most drugs, and also hyperkalemia or ischemia. So the classification, class 1 action is sodium channel blockade, with the subclass reflects the effects on the action potential duration as APD and the kinetics of sodium channel blockade. So with class 1A action, it prolongs the action potential duration as the APD and dissociates from the channel with intermediate kinetics. With class 1B action, it shortens the APD in some tissues of the heart and dissociate from the channel with rapid kinetics. And class 1C action have minimal effects on the APD and dissociate from the channel with slow kinetics. With class 2 action, the action is sympatholytic, like I said, beta blockers. They reduce the beta adrenergic activity of the heart. Class 3 action is it manifests as a prolongation of the action potential duration, and most drugs with this action block the rapid components of the delayed rectifier potassium current, and that's the IKR. With class 4, like I said, has to do with the calcium channels. So the action is the blockade of the cardiac calcium currents. It slows conduction in the regions where the action potential of stroke is calcium dependent, for example in the SA node and the AV node. So a given drug may have multiple classes of action as indicated by its membrane and electrocardiography effect And for example, amiodarone shares all the four classes of action, and certain antiarrhythmic agents, for example, adenosine and magnesium, do not fit readily into this classification. So with class 1, the sodium channel blocking drugs with local anesthetic action block sodium channels and reduce the sodium current. And they are the oldest group of antiarrhythmic drugs and are still widely used, with class 1A being procaine, quinidine, and disopyramide, with class 2 being lidocaine, mesalazine, tokenide. You can think of phenytoin too, and class 1C, flecainide, nkinide. So remember, tokenide, class 1B, and class 1C, flecainide, nkinide, propafenone, and also morphine. Okay, so here the direct effect of class 1A drugs on the action potential is significantly modified by anticholinergic actions. So a drug like procainamide, the anticholinergic effect is very weak. Quinidine, it's moderate. Disopyramide is very strong. Alright, so procainamide, it slows the upstroke of action potential, which slows conduction and prolongs the QRS complex duration of the ECG, and also prolongs the action potential duration as a class 3 action by non-specific blockade of the potassium channels, and less effective than quinidine in suppressing abnormal ectopic pacemaker activity, but more effective in blocking the sodium channels in depolarized cells. Procainamide has direct depressant actions on the sinoatrial and the AV nodes, and these actions are only slightly counterbalanced by drug-induced vagal block. Extra cardiac effects including ganglion blocking properties, and this action reduces peripheral vascular resistance and cause hypertension, particularly with IV use. But when in therapeutic concentrations, its peripheral vascular effects are less prominent than those of quinidine, and hypertension is usually associated with excessively rapid procainamide infusion or the presence of severe underlying left ventricular dysfunction. Okay, so it has several toxic effects, like I said earlier on. Cardiotoxicity, where excessive action potential prolongation could occur, QT interval prolongation, induction of torsades de pointes, arrhythmia, and also syncope. Like I said, induction of torsades de pointes, arrhythmia, and also syncope. So excessive slowing of conduction, precipitation of new arrhythmias could occur from procainamide use. Even systemic lupus erythematosus-like syndrome consisting of arthralgia and arthritis with long-term therapy could occur. And serologic abnormalities, for example, anti-nuclear antibody titer, occur in nearly all patients, and in the absence of symptoms, these are not an indication to stop therapy, drug therapy, or long-term therapy. That's with the serologic abnormalities. Also, pleuritis, pericarditis, or parenchymal pulmonary disease could occur, nausea and diarrhea in about 10% of cases, rash, fever, hepatitis in less than 5%, and also agranulocytosis in about 0.2%. So for procainamide pharmacokinetics, the route is peroral, IV, or IM, and with the metabolism and the elimination is eliminated by hepatic metabolism to N-acetyl procainamide, with this NAPA, and with it has a half-life of 3 to 4 hours. Frequent dosing or use of a slow release formulation is the usual practice, and half-life for NAPA is longer, with a with the measurement, or we measure the plasma levels of both prokinamide and NAPA, especially in patients with circulatory or renal impairment. And NAPA has class 3 activity, eliminated by the kidneys to reduce those in renal failure. Excessive accumulation is implicated in Torsades stay points, especially in renal failure, and is reduced VD in renal clearance associated with heart failure. Requires reduction in dosage. So with more on the prokinamide therapeutic uses, could be used in atrial and ventricular arrhythmias, like I said. So many clinicians attempt to avoid long-term therapy because of the requirements of frequent dosing and the common occurrence of the lipose-related effects. And prokinamide is a drug of second or third choice after lidocaine or amiodarone in most coronary care units for the treatment of sustained ventricular arrhythmias associated with acute myocardial infarction. So with quinidine, the side effects include cardiac effects, same as prokinamide, and then its toxic cardiac effects include excessive QT, interval prolongation, and induction of the saddest day point. And with the toxic concentration of quinidine, also produces excessive sodium channel blockade with slowed conduction throughout the heart, with extra cardiac effects, with adverse effects on the GIT, causing nausea, diarrhea, vomiting, and these are observed in about 1/3 to 50% of the patients. The syndrome of headache, dizziness, tinnitus, synchronism is observed at toxic heart concentrations. Idiosyncratic or immunologic reactions, including thrombocytopenia, hepatitis, angioneurotic edema, and fever, observed rarely. With the more on the pharmacokinetic and therapeutic use, quinidine is readily absorbed from GIT tract and eliminated by hepatic metabolism, and is rarely used because of cardiac and extra cardiac adverse effects and availability of better tolerated antiarrhythmic drugs. With disopyramide, it has several cardiac effects which are very similar to those of prokinamide and quinidine, and its cardiac antimuscarinic effects are more marked than those of quinidine. Therefore, drug that slows AV conduction should be administered with disopyramide when treating atrial flutter or fibrillation, and sometimes calcium channel blockers or beta blockers have to be added. With the toxic effect, more on it, the toxic concentrations can precipitate all the electrophysiologic disturbances described under quinidine. So, as a result of its negative inotropic effect, it may precipitate heart failure de novo in patients with persistent depression of left ventricular function. So it's not the first line antiarrhythmic agent, and it should not be used in patients with heart failure. Disopyramide's atropine-like activity accounts for most of its symptomatic not symptomatic, but its symptomatic adverse effects, like urinary retention, most often in male patients with prostatic hyperplasia, dry mouth, blurred vision, constipation, and worsening of persistent glaucoma, and these effects may require discontinuation of the drug. More on the pharmacokinetics and therapeutic use, of course, oral use, oral routes, and in patients with renal impairment, the dosage must be reduced, and due to the danger of precipitating heart failure, loading doses are not recommended. It's effective in a variety of supraventricular arrhythmias, but approved mainly for the treatment of ventricular arrhythmias. Lidocaine has a low incidence of toxicity and a high degree of effectiveness in arrhythmias associated with acute myocardial infarction, and it's usually by IV route. So the cardiac effect is that it blocks activated and inactivated sodium channels with rapid kinetics. The inactivated states block ensures greater effects on cells with long action potentials, for example, the Purkinje and ventricular cells, compared with atrial cells. And the rapid kinetics at normal resting potentials results in recovery from block between the action potentials and no effect on conduction. So the increase in activation is lower up on binding kinetics results in the selective depression of conduction in depolarized cells, and little effect is seen on the ECG in normal sinus rhythm. With the toxicity, lidocaine is one of the least cardiotoxic of the currently used sodium channel blockers and proarrhythmic effects, including SC, node arrest, worsening of impaired conduction, and ventricular arrhythmias are common with lidocaine use. So, in large doses, especially in patients with persistent heart failure, lidocaine may cause hypertension, partly by depressing myocardial contractility. And lidocaine's most common adverse effects, like those of other local anesthetics, are neurologic. Paresthesias, tremors, nausea of central region, lightheadedness, hearing disturbances, slurred speech, and convulsions. And these occur most commonly in elderly or otherwise vulnerable patients, or when a bolus of drug is given too rapidly, and the effects are dose related and usually short-lived. Seizures respond to intravenous diazepam. More on the pharmacokinetics, and undergoes extensive phase-pass metabolism, about 97%. So it's given by IV routes, and occasionally patients with myocardial infarction or other acute illness require higher concentrations, and they can actually tolerate those higher concentrations. So this may be due to increased plasma alpha 1 acid glycoprotein and acute phase reactant protein that binds lidocaine, making less free drug available to exert its pharmacologic effect. So in patients with heart failure, lidocaine's VD and total body clearance may both be decreased, and therefore both the loading and maintenance doses should be decreased. And in patients with liver disease, the plasma clearance is markedly low, and in the VD is often high, and the elimination half-life in such cases may be increased threefold or more. And in liver disease, the maintenance dose should be decreased, but usual loading doses can be given. And drugs that decrease liver blood flow, like propranolol, cimetidine, they reduce lidocaine clearance and so increase the risk of toxicity unless infusion rates are decreased. So lidocaine's therapeutic use is an agent of choice for termination of ventricular tachycardia and prevention of ventricular fibrillation after cardioversion in the setting of acute ischemia. However, the routine prophylactic use of lidocaine in this setting may actually increase total mortality, possibly by increasing the incidence of asystolia, and is not the standard of care. And most physicians administer IV lidocaine only to patients with arrhythmias. For meselectin, it's an orally active congener of lidocaine, and its electrophysiologic and antiarrhythmic actions are similar to those of lidocaine. The anticonvulsant phenytoin also exerts similar electrophysiologic effects and has been used as an antiarrhythmic. And for meselectin, it's used in the treatment of ventricular arrhythmias, like I said, and the elimination half-life is 8 to 20 hours, and it permits administration of 2 to 3 times per day. But the dose-related adverse effects are seen frequently at therapeutic doses. These are predominantly neurologic, including tremor, blurred vision, lethargy. With nausea, is also a common effect. Meselectin has also shown significant efficacy in relieving chronic pain, especially pain due to diabetic neuropathy and nerve injury, and this application is off-label. Alright, let's look at flecainide. So flecainide is a potent blocker of sodium and potassium channels with slow unblocking kinetics. Although it blocks certain potassium channels, it does not prolong the action potential or the QT interval. It's currently used for patients with otherwise normal hearts who have supraventricular arrhythmias, and it has no antimuscarinic effect. Flecainide is very effective in suppressing premature ventricular contractions. However, it may cause severe exacerbation of arrhythmia even when normal doses are administered to patients with persistent ventricular tachyarrhythmias and those with previous MI and ventricular ectopy. So flecainide is well absorbed and has a half-life of approximately 20 hours, and elimination is both by hepatic metabolism and by the kidney. And the usual dosage of flecainide is 100 to 200 milligrams twice a day. Propafenone has some structural similarities with propranolol and possesses weak beta blocking activity. Its spectrum of action is very similar to that of quinidine, but it does not prolong the action potential. Its sodium channel blocking kinetics are similar to that of flecainide, and propafenone is metabolized in the liver with an average half-life of 5 to 7 hours. The drug is usually used primarily for supraventricular arrhythmias, and the most common adverse effects are the metallic taste and constipation symptoms that it shows. Well, it has this effect, this arrhythmic exacerbation effect, and this can occur with propafenone use. For Morrisizin is an antiarrhythmic phenothiazine derivative that was used for the treatment of ventricular arrhythmias, and it's relatively potent sodium channel blocker that does not prolong action potential duration. Alright, so for phase class 2, you remember beta blockers, so beta adrenoceptor blocking drugs like propranolol, esmolol, sotalol. For these antiarrhythmic properties, they are due to their beta receptor blocking action and direct membrane effects, and some have selectivity for cardiac beta 1 receptors, and some have intrinsic sympathomimetic activity. Some have marked direct membrane effect, and some prolong cardiac action potential. The relative contributions of the beta blocking and direct membrane effects to antiarrhythmic effects of these drugs are not fully known. Although beta blockers are fairly well tolerated, their efficacy for suppression of ventricular ectopic depolarizations is lower than that of sodium channel blockers. However, these agents can prevent recurrent infarction and also sudden death in patients recovering from acute MI. Esmolol is a short-acting beta blocker used primarily as an antiarrhythmic drug for intraoperative and other acute arrhythmias, and has a short half-life, about 10 minutes. During continuous infusion of esmolol, steady-state concentrations are achieved quickly, and the therapeutic action of the drug are terminated rapidly when its infusion is discontinued. And esmolol may be safer to use than longer acting antagonists in critically ill patients who require beta adrenoceptor antagonists. Sotalol is a non-selective beta blocking drug that prolongs the action potential like class 3 action. With the class 3 actions, remember the potassium channel blockers. Drugs prolong effective refractory fluid by prolonging the action potential, and I've already mentioned some of the drugs like amiodarone, dromidarone, celivaron, venacalant, sotalol, dophytilide, and ibutylide. So these drugs prolong action potential. The action potential prolongation often exhibits the undesirable property of reverse use dependence. So at this point, the action potential prolongation is least marked at fast rates where it is desirable, and most marked at slow rates where it can contribute to race of the point. Although the most drugs in the class evoke QT prolongation, there is considerable variability among drugs in their pro-arrhythmic tendency to cause the the point, despite significant QT interval prolongation. So aminodarone is approved for oral intravenous use to treat serious ventricular arrhythmias. However, the drug is also highly effective for the treatment of supraventricular arrhythmias, such as atrial fibrillation. As a result of this broad spectrum of antiarrhythmic action is very extensively used for a wide variety of arrhythmias. Amiodarone has unusual pharmacokinetics and important extra cardiac adverse effects. Dronidarone, which is an analog that lacks iodine atoms, is for the treatment of atrial flutter and fibrillation, and salivarone is another non-iodinated benzofuran derivative, similar to dronidarone, that is for the prevention of ventricular tachycardia recurrence. With the cardiac effects during chronic administration, these IKs are also blocked, and the action potential duration is prolonged uniformly over a wide range of heart rates. That is, the drug does not have reverse use dependence action. In spite of its present classification as class 3 agent, amiodarone also significantly blocks inactivated sodium channels, and its action potential prolonging action reinforces this effect. Amiodarone also has weak adrenergic and calcium channel blocking actions, and consequences of these actions include slowing of the heart rate and AV node conduction. The broad spectrum of actions may account for its relatively high efficacy and its low dependence of the points despite significant QT interval prolongation. Extracardiac effects include amiodarone causing peripheral vasodilation, and this action is predominant after intravenous administration and may be related to the action of the vehicle. With the toxicity, may produce symptomatic bradycardia and heart block in patients with pre-existing sinus or AV node disease, and the drug accumulates in many tissues, including the heart rate. That's 10 to 50 times more so than in plasma. Liver, the lungs, the skin, and it's concentrated in tears. Those related pulmonary toxicity is the most important adverse effects, and even on low dose of 300 milligrams per deciliter or less, fatal pulmonary fibrosis may be observed in 1% of patients. Abnormal LFTs and hypersensitivity hepatitis may develop during amiodarone treatment, and LFs should be monitored regularly. The skin deposits results in a foot-to dermatitis and a gray-blue skin discoloration in sun-exposed areas, for example, the malar regions. After a few weeks of treatment, asymptomatic corneal microdeposits are present in virtually all patients treated with amiodarone. Halos develop in the peripheral visual fields of some patients, and drug discontinuation is usually not required early, and optic neuritis may progress to blindness. Amiodarone blocks the peripheral conversion of tyrosine, that's T4, to triiodothyronine T3, and it's a potential source of large amounts of inorganic iodine. And amiodarone may result in hypothyroidism or hyperthyroidism, and thyroid function should be evaluated before initiating treatment and should be monitored periodically because effects have been described in virtually every organ system. Amiodarone treatment should be re-evaluated whenever new symptoms develop in a patient, including arrhythmia, aggregation. With the pharmacokinetics, amiodarone is variably absorbed with a bioavailability of 35 to 65%. It undergoes hepatic metabolism, and a major metabolite, tau amiodarone, is bioactive. So the elimination half-life is complex with a rapid component of 3 to 10 days, that's about 50% of the drug, and a slower component of several weeks. After discontinuation of the drug, effects are maintained for 1 to 3 months. Measurable tissue levels may be observed up to 1 year after discontinuation. Pharmacologic effects may be achieved rapidly by intravenous loading. QT prolonging effect is modest with this route of administration, whereas bradycardia and AV block may be significant. Amiodarone has many important drug interactions, and all medications should be reviewed when the drug is initiated and when the dose is adjusted. So amiodarone is a substrate for liver cytochrome CYP3A4, and its levels are increased by drugs that inhibit this enzyme, for example the histamine H2 blocker cimetidine, and drugs that induce CYP3A4, for example rifampin, decrease amiodarone concentrations when co-administered. Amiodarone inhibits several cytochrome P450 enzymes and may result in high levels of many drugs, including statins, digoxin, and warfarin. And dose of warfarin should be reduced by 1/3 of up to half following initiation of amiodarone, and thrombin times should be closely monitored. So more on the therapeutic use. Low doses like 100 to 200 milligrams per of amiodarone are effective in maintaining the normal sinus rhythm in patients with atrial fibrillation. The drug is effective in prevention of recurrent ventricular tachycardia. It's not associated with an increase in mortality in patients with CAD or heart failure. Implanted cardioverter defibrillator (ICD) has succeeded drug therapy as the primary treatment modality for ventricular tachycardia, but amiodarone may be used for ventricular tachycardia as adjuvant therapy to decrease the frequency of uncomfortable cardioverter defibrillator changes, and the drug increases the defibrillation threshold, and these devices require retesting after maintenance dose has been achieved. Dronedarone, this drug was intended to eliminate action of the drug action on tyrosine metabolism and to modify the half-life of the drug. And no thyroid dysfunction or pulmonary toxicity has been reported in short-term studies. However, drug liver toxicity, including severe cases requiring liver transplantation, has been reported. Dronedarone has multi-channel actions, including blocking potassium, calcium, and sodium currents, and it has beta-adrenergic blocking action. Drug has a half-life of 24 hours and can be administered twice daily at a fixed dose of 400 milligrams. Dronedarone absorption increases to threefold when taken with food, and this information should be communicated to patients as a part of the dosing instructions. Dronedarone elimination is primarily non-renal. However, it inhibits tubular secretions of creatinine, resulting in a 10 to 20% increase in serum creatinine. Was GFR is unchanged, no adjustments are required, and dronedarone is both a substrate in and an inhibitor of CYP3A4 and should not be co-administered with potent inhibitors of this enzyme, such as the azole and similar antifungal agents and protease inhibitors. Dronedarone restores sinus rhythm in a small percentage of patients, that's less than about 15% with atrial fibrillation, and produces a 10 to 15 beats per minute reduction of the ventricular rate compared to placebo. Dronedarone doubled the interval between episodes of atrial fibrillation recurrence in patients with paroxysmal atrial fibrillation. Initial studies suggest a reduction in mortality or hospitalization in patients with atrial fibrillation. However, study of dronedarone effects in permanent atrial fibrillation was terminated in 2011 because of increased risk of death, stroke, and heart failure. Similarly, a trial of dronedarone in advanced heart failure was terminated prematurely because of an increase in mortality. The drug carries a black box warning against its use in acute decompensated or advanced class 4 heart failure. Venacalant, well, there's a limited success. The limited success of highly specific drugs that target single ion channels, and the efficacy of multi-ion channel blockers such as amiodarone have shifted the emphasis in antiarrhythmic drug development to the latter class of drugs. Venacalant is a multi-ion channel blocker that was developed for the treatment of atrial fibrillation, and Venacalant prolongs the atrial effective refractory period and slows conduction over the AV node. Ventricular effective refractory period is unchanged, and in the maximal clinical dose of 1,800 milligrams per day, Venacalant does not change the QT interval on the ECG. Actually blocks ultra rapid potassium current, as well as acetylcholine and outward transient currents, and these currents play key roles in atrial repolarization, and their block accounts for the prolongation of the atrial effective refractory period. Drug is less potent blocker of IKR, and as a result produces less APD, exponential duration prolongation in the ventricle. That is, the APD prolonging effect is relatively atrium specific. Venacalant also produces use-dependent block of the sodium channel. Recovery from the block is fast, such as significant blockade. Well, the significant blockade is observed only at fast rates or at low membrane potentials, and the therapeutic concentration range. Venacalant has no effect on heart rate, toxicity, and pharmacokinetics. The therapeutic uses or adverse effects of Venacalant include dysgeusia, that is disturbance of taste, sneezing, paresthesia, cough, and hypertension. And pharmacokinetic data of for Venacalant is it's so limited. After IV administration, the drug is metabolized in the liver by CYP2D 6 cytochrome P2D6 with a half-life of 2 hours. Intravenous venacalant is effective in converting recent onset atrial fibrillation to normal sinus rhythm in about 50% of patients. Sotalol has both beta adrenergic receptor blocking, that's class 2, and action potential prolonging, as class 3 actions, and the drug is formulated as a racemic mixture of D and L sotalol. All the beta adrenergic blocking activity resides in the L isomer, and D and L isomer share action potential prolongation actions. The beta blocking action is not cardio selective and its maximal doses below those requiring for action potential prolongation. Sotalol is well absorbed orally with bioavailability of approximately 100% and is not metabolized in the liver and is not bound to plasma proteins. Excretion is predominantly by the kidneys in the unchained form with a half-life of approximately 12 hours. Because of its relatively simple pharmacokinetics, sotalol exhibits few action direct drug interactions. Its most significant cardiac effect is an extension of its pharmacologic action. Okay, those related incidence of torsades, the point that approaches about 6% of the highest recommended daily dose. And patients with overt heart failure may experience further depression of the left ventricular function during treatment with sotalol. Sotalol is approved for the treatment of life-threatening ventricular arrhythmias and the maintenance of sinus rhythm in patients with atrial fibrillation. And it's also approved for treatment of supraventricular and ventricular arrhythmias in the pediatric age group. Sotalol decreases the threshold for cardiac defibrillation. Dofetilide has 3 action potential prolongation action. This action is effected by a dose-dependent blockade of the rapid component of the delayed rectifier potassium current. Blockade of the delayed rectifier potassium current increases in hypokalemia. So the action is effective by a dose-dependent blockade of the rapid component of the delayed rectifier potassium currents, that's the IKR, and the blockade of the IKR increases in hypokalemia, and it produces no relevant blockade of the other potassium channels or the sodium channels. But because of the slow rate of recovery from blockade, the extent of blockade shows little dependence on stimulation frequency. However, dofetilide shows less action potential propagation at rapid rates because of the increased importance of other potassium channels, such as the delayed rectifier sodium channels, potassium channels, IKS at higher frequencies. Dofetilide is 100% bioavailable, and verapamil increases peak plasma dofetilide concentration by increasing intestinal blood flow. 80% of an oral dose is eliminated unchanged by the kidneys, and the rest is eliminated in the urine as inactive metabolites. Inhibitors of the renal cation secretion mechanism, for example, samidin prolongs its half-life, and since the QT prolonging effect and risks of ventricular proarrhythmia are directly related to plasma concentration dosage, The dosage must be based on the estimated creatinine clearance, and treatment should be initiated in hospital after baseline measurement of the rate corrected QT interval and serum electrolytes. The a baseline QTC of more than 150 millisecond, that's 500 millisecond, in the presence of an intraventricular conduction delay, bradycardia of less than 50 beats per minute, and hypokalemia, relative contraindications to its use. And Endophytolite is approved for the maintenance of normal sinus rhythm in patients with atrial fibrillation, and it's also effective in restoring normal sinus rhythm in patients with atrial fibrillation. Ibutylite, like dofitylite, slows cardiac depolarization by blockade of the rapid component, um, as IKR of the delayed rectifier potassium current, and activation of slow inward sodium current has also been suggested as an additional mechanism of action potential prolongation. And after IV administration, ibutylite is rapidly cleared by hepatic metabolism, and the metabolites are excreted by the kidney, and elimination of life averages about 6 hours. IV ibutylite is also used for the acute conversion of atrial flutter and atrial fibrillation to normal sinus rhythm. The drug is more effective in atrial flutter than atrial fibrillation, with a mean time to termination of 20 minutes. The most important adverse effect is excessive QT interval prolongation, and to set the point, and patient required continuous ECG monitoring for 4 hours after ibutylite infusion or until QT returns to baseline. For class 4, as a calcium channel blockers drug, verapamil and dotriazine. Verapamil, the cardiac effect is that it blocks both the activated and inactivated L-type calcium channels, and AV nodal conduction time and effective refractory period are consistently prolonged by therapeutic concentration. Verapamil usually slows the sinoatrial node by its direct action, but its hypotensive action may occasionally result in a small reflex increase in sinoatrial rate, nodal rate. And with the extra cardiac effect, verapamil causes peripheral vasodilation, which may be beneficial in hypertension and peripheral vasospastic disorders. And toxicity, cardiotoxic effects are dose related and usually avoidable. A common error has been to administer IV verapamil to a patient with ventricular tachycardia, misdiagnosed as supraventricular tachycardia. In this setting, hypertension and ventricular fibrillation can occur. Verapamil's negative inotropic effect may limit its clinical usefulness in disease hearts. Verapamil can induce AV block when used in large doses or in patients with AV nodal disease, and this block can be treated with atropine and beta receptor stimulants. Adverse extra cardiac effects include constipation, lassitude, nervousness, and peripheral edema. And the half-life of verapamil is approximately 7 hours and is extensively metabolized by the liver after oral administration. Its bioavailability is only about 20%. Therefore, verapamil must be administered with caution in patients with hepatic dysfunction or impaired hepatic perfusion. In adult patients without heart failure or sinoatrial AV nodal disease, parenteral verapamil can be used to terminate supraventricular tachycardia, although adenosine is the agent of first choice. More on the therapeutic uses. The supraventricular tachycardia is major arrhythmia indication. Adenosine and verapamil are preferred over older treatments like propranolol, digoxin, hydrophonium, and vasoconstrictor agents. And cardio conversion for termination. Verapamil can also reduce the ventricular rate in atrial fibrillation and flutter. It only rarely converts atrial flutter and fibrillation to sinus rhythm. Verapamil is occasionally useful in ventricular arrhythmias. However, IV verapamil in patients with sustained ventricular tachycardia can cause hemodynamic collapse. Diltiazem appears to be similar in efficacy to verapamil in the management of supraventricular tachycardias, supraventricular arrhythmias, including rate control in atrial fibrillation. An intravenous form of diltiazem is available for the later indication and causes hypertension or bradyarrhythmias relatively infrequently. And more on other miscellaneous or antiarrhythmic agents. Certain agents used for treatment of arrhythmias do not fit the controversial non-classes or the conventional class 1 to 4 organizations, and these include digitalis, adenosine, magnesium, and potassium. Like I said, these other certain drugs or non-arrhythmic drugs, such as drugs acting on the renin-angiotensin aldosterone system, fish oil, and statins, can reduce recurrence of tachycardias and fibrillation in patients with CAD or congestive heart failure. Adenosine is a naturally occurring nucleoside throughout the body, and its half-life is in blood is less than 10 seconds. Its mechanism of action involves activation of the inward rectifier potassium current and also inhibition of the calcium current, and these cause marked hyperpolarization and suppression of calcium dependent potassium channel action potentials. And when given as a bolus, it directly inhibits AV nodal conduction, increases the AV nodal refractory period, but has lesser effect on the sinoatrial node. Adenosine is currently the drug of choice for prompt conversion of paroxysmal supraventricular tachycardia to sinus rhythm because of its high efficacy. It's about 90 to 95% and very short duration of action. The uncommon variant of ventricular tachycardia is adenosine sensitive. A drug is less effective in the presence of adenosine receptor blockers such as theophylline or caffeine, and its effects are potentiated by adenosine uptake inhibitors such as dipyridamole. So with toxicity, adenosine causes flushing in about 20% of patients and shortness of breath or chest burning, perhaps related to bronchospasm in about 10%. So induction of high-grade AV block may occur, but is very short-lived, and atrial fibrillation may also occur. Less common toxicities include headaches, hypertension, nausea, paresthesias, and with magnesium, is originally used for patients with digitalis-induced arrhythmias who were hypomagnesic. Magnesium infusion has been found to have antiarrhythmic effects in some patients with normal serum magnesium levels. The mechanisms of these effects are not known, but magnesium is recognized to influence the sodium potassium ATPase, also sodium channels, and certain potassium channels and calcium channels. So magnesium therapy is indicated in patients with digitalis induced arrhythmias if hypomagnesemia is present, and it's also indicated in some patients with pulsatile points, even in serum magnesium, even if the serum magnesium is normal. With potassium, the effects of increasing serum potassium can be summarized as: 1, arresting potential depolarization action, and 2, a membrane potential stabilizing action. And the latter is caused by increased potassium permeability. Hypokalemia results in increased risk of early and delayed after depolarizations and ectopic pacemaker activity, especially in the presence of digitalis. And hyperkalemia depresses ectopic pacemakers. For example, severe hyperkalemia is required to suppress the SCA node and slows conduction. Um, both because both insufficient and excess potassium is potentially um, arrhythmogenic. Potassium therapy is directed towards normalizing potassium gradients and pools in the body. And with the principles in clinical use of antiarrhythmic agents, the margin between efficacy and toxicity is particularly narrow for antiarrhythmic drugs. The risks and benefits must be carefully considered. With pre-treatment evaluation, several important steps must be taken before initiation of any antiarrhythmic therapy, with the first being elimination of the cause. So eliminate the cause. Precipitating factors must be recognized and eliminated if possible, and these include abnormalities of internal homeostasis, such as hypoxia or electrolyte imbalance, especially hypokalemia or hypomagnesemia, and drug therapy and underlying disease states such as hyperthyroidism or cardiac disease. It is important to separate these abnormal substrates from triggering factors such as myocardial ischemia or acute cardiac dilatation, and which may be treatable and reversible by different means. So make a firm diagnosis. A firm arrhythmia diagnosis should be established. For example, the misuse of verapamil in patients with ventricular tachycardia, mistakenly diagnosed as supraventricular tachycardia, can lead to catastrophic hypotension and cardiac arrest. And as increasingly sophisticated methods to characterize underlying arrhythmia mechanisms become available and are validated, it's very much it may be possible to direct certain drugs or specific arrhythmia mechanisms. Alright, so the third point you can think of here is you have to determine the baseline condition. So underlying heart disease is critical determinant of drug selection for a particular arrhythmia in a particular patient. So a key question is whether the drug is structurally abnormal. A few antiarrhythmic drugs have documented safety in patients with congestive heart failure or ischemic heart disease, and some drugs pose pro-arrhythmic risk in certain disease states. For example, class 1C drugs in patients with ischemic heart disease. Okay, so a reliable baseline should be established against which to judge the efficacy of any subsequent antiarrhythmic intervention, and several methods are now available for such baseline quantification. These include prolonged ambulatory monitoring, electrophysiologic studies that reduce a target arrhythmia, reproduction of a target arrhythmia by treadmill exercise, or the use of telephonic monitoring for recording of sporadic but symptomatic arrhythmias. And the fourth point here is we have to question the need for therapy. The mere identification of abnormality of cardiac arrhythmia or cardiac rhythm does not necessarily require the arrhythmia to be treated. So there are benefits and risks, and two types of benefits that can be envisioned: reduction of arrhythmia related symptoms such as palpitations, syncope, or cardiac arrest, and also reduction in long-term mortality in asymptomatic patients. So among drugs discussed here, only beta blockers have been definitely associated with the reduction of mortality in relatively asymptomatic patients. The mechanism underlying this effect is not established. Antiarrhythmic therapy carries with it a number of risks, and in some cases the risk of an adverse reaction is clearly related to high doses or plasma concentrations. So examples include lidocaine induced tremor or quinidine induced synchronism. And in other cases, adverse effects are unrelated to high plasma concentrations. For example, procainamide induce agranulocytosis. And for many serious adverse reactions to antiarrhythmic drugs, the combination of drug therapy and underlying heart disease requires or appears very important. Several specific syndromes of arrhythmia provocation by antiarrhythmic drugs have been identified, each with underlying pathophysiologic mechanisms and risk factors. So drugs such as quinidine, sotalol, ibutylide, dofetilide, which act at least in part by slowing hyperpolarization and prolonging cardiac action potentials, can result in marked QT prolongation. Because at the point, treatment of the points require recognition of the arrhythmia, withdrawal of any offending agent, correction of hypokalemia, and treatment with maneuvers to increase the heart rate, pacing, or isoproterenol. Also, intravenous magnesium also appears effective even in patients with normal magnesium levels. The drugs that magnesium slow conduction, such as flecainide or high concentrations of quinidine, can result in an increased frequency of re-entry arrhythmias, notably ventricular tachycardia in patients with prior MI, in whom a potential re-entry circuit may be present. The treatment here consists of recognition, withdrawal of offending agent, and intravenous sodium. And also with the agency of clinical situation determines the route and administration of drug initiation. With this, we are talking about the conduct of antiarrhythmic therapy, and when immediate drug action is required, the intravenous route is preferred. Therapeutic drug levels can be achieved by administration of multiple slow intravenous boluses, or the drug therapy it can be considered effective when the target arrhythmia is suppressed according to the measure used to quantify it at baseline, and also toxicities absent if they are absent. Conversely, drug therapy should not be considered ineffective unless toxicities occur at a time when arrhythmias are not suppressed. And monitoring plasma concentration, drug concentration, can be useful agents to managing antiarrhythmic therapy, and plasma drug concentrations are also most important in establishing compliance during long-term therapy, as well as detecting drug interactions that may result in very high concentrations at low doses, low drug doses, or very low concentrations at high doses. Right, so that's it for anti-arrhythmic drugs or anti-arrhythmic agents.